Today, we're going to dive into two of the biggest principles in medical ethics: beneficence, which is the duty to do good, and non-maleficence, the duty to do no harm. And to really get our heads around them, we're going to put you, yes you, right in the middle of a life or death decision. Let's jump right in. So picture this. A patient's heart stops, they're coding, the whole medical team is ready to spring into action, but the one piece of paper that's supposed to guide them, the patient's chart, is totally silent on what to do next. What happens when the official record says nothing, but you think you know what the plan was? All right, so let's step into this hypothetical case. Now remember, this is a scenario we're exploring, designed to push us into a really tough ethical corner, a place where life is literally hanging in the balance. Okay, let's meet our patient. She's a 62-year-old woman, and she's been battling severe COPD. That's chronic obstructive pulmonary disease, which makes it incredibly hard for her to breathe. This isn't her first time in the hospital. It's actually her 6th admission for this. And here's the tough part. Her condition is just getting worse over time. And then it happens. 5 days into her hospital stay, her heart and lungs just stop. This is that critical moment, the one you see in movies, where every single second counts, and having a clear plan is everything. But this is where things get really complicated. The emergency itself is straightforward, but the right response is anything but. And it all boils down to an order that was never written down. So the person running the show in that moment is the chief resident. As the team is rushing around, a memory suddenly hits them, a conversation from just 3 days before, and that memory changes everything. And this right here is the heart of the problem. On one side, you have what was said. The chief resident is positive they heard the senior doctor, the attending physician, say he was going to put her on a no-CPR status. But on the other side, you have what's written. And what's written is nothing. The official legal medical record, totally blank on this. And if that wasn't enough, the pressure just keeps mounting. The resident frantically tries to call the attending physician, no answer. The patient's family, the people who could maybe tell them what she would have wanted, they're not there. All the resident has to go on is that one official but totally empty document. So, all of this leads to what feels like an impossible choice. A decision has to be made. Right now, with incomplete information, and the consequences, well, they're enormous. So I want you to put yourself in their shoes for a second. The crash cart rolls in, the entire team is staring at you, waiting for the order. What do? Do you start CPR knowing it might go against the patient's wishes and your boss's plan? Or do you hold back, based on nothing more than a memory? To figure this out, you can't just go with your gut. You need a framework. And in medicine, that framework is built on core ethical principles. There are two that are absolutely crucial right here. First up, we've got beneficence. This is the principle that pushes doctors to act. It's the duty to do good, to take positive steps to help the patient. You can think of it as the do good principle. Simple as that. And on the flip side, there's non maleficence. Now, this is probably the one you've heard of before, thanks to the famous Latin phrase primum non nocere, which means first, do no harm. This is a principle of holding back, of being careful not to cause more pain or suffering. Okay, so we've got these two big ideas, doing good and not doing harm. How on earth do they help our resident make this impossible choice? Well, let's walk through the ethical verdict. First things first, let's be clear about something. A no-CPR order, or a DNR, is not automatically a bad thing. In fact, in some situations, it's actually the most compassionate and ethical choice you can make. Usually, a doctor might consider a no-CPR order if a patient's illness is terminal, if there's very little chance they'll recover, or if the stress and pain of treatment is just too much for the patient or their family. And, you could make a pretty strong case that our patient, with her worsening COPD, might fall into that category. But, and this is the absolute key, even though there was a conversation, the ethically correct choice, because nothing was put into writing, is to start CPR. So let's break down why that's the right call. Let's go through it step by step. 1. The written record is king. If there's no written order, the default position, always, is to try and save a life. 2. When in doubt, you have to err on the side of action. This is beneficence in action. It's far better to give care that might help than to withhold it and cause certain harm. 3. Respect the chain of command. Look, the resident just doesn't have the authority to make this call. And finally, step 4. You have to consider that the senior doctor might have changed his mind. Maybe the reason it wasn't written down is because he decided against it. So when you put all that together, the conclusion is crystal clear. The chief resident's duty, ethically and professionally, is to forget the memory of that conversation and act on what's in the chart. And since the chart is empty, that means starting CPR immediately. And that really leaves us with a bigger question, one that goes way beyond the walls of a hospital. When you're facing a crisis with incomplete information, what's actually more dangerous? Taking a difficult, maybe even flawed action, or choosing an inaction that could be final and devastating? It's definitely something to think about.